Freedom HealthWorks is the direct primary care accelerator. We help doctors across the country start fresh in direct primary care. With Freedom HealthWorks, you work with a team, not a checklist. Visit freedomhealthworks.com and together we can achieve true freedom in direct care.
Joining me today is Peyton Vooletich of the Emergency Center, a physician-owned, independent, freestanding ERs in Texas. Peyton, where did this idea come from?
First, let me say thank you for having me. I'm excited to let your listeners know a little bit more about us. How we came to be, we're actually, like you said, we're a physician-owned, all of them were ER physicians, and they saw a real need. They saw that just the fact that somebody was coming in with an emergency situation and having to pay these crazy deductibles, they just felt like that was wrong altogether. And, and a lot of times being penalized for going to the ER by their employer because it actually wasn't an emergency. It was just, acid reflux or a panic attack. It actually wasn't a heart attack. So they decided to create these freestanding ERs and offer, just a different experience altogether. We're 24/7, 365, but we guarantee no wait. You will leave with a, the 3-day med pack. We have, CT options, we have imaging, we have lab, all on site, observation capabilities for 23 hours. And it's really a concierge experience and transparent pricing. So that was really important to them, and they're really passionate about it. And I have become very passionate about it as well.
So you listed off a lot of services that you're able to provide there and a lot of things that could be very, very attractive to people. Is there one of those items, so no waits, meds, labs on site, is there one that makes the emergency center more attractive to people?
I think that the fact that there is no wait, when we're hearing stories about people, having chest pains and they're going to the emergency room and they're waiting for 4 or 5 hours in the emergency room, and just recently heard of a 34-year-old woman who died in a waiting room waiting, and she had cardiac arrest. So I think the no wait is huge. And, we kind of have a plan in place to guarantee the no wait, and it's been working for us. And so I think that right off the bat is really important to people.
Yeah, I think so. And especially when you say, people are dying in waiting rooms or going through immense amount of pain, suffering. So tell us, take a step back here, Peyton. Tell us kind of from a 30,000 foot view, how this works. How does the emergency center work when so many people are saying, oh, this is the one area of healthcare that, it's going to be the hardest to change, but you guys are changing it. How?
We are, the emergency center has partnered with On Deck Health, and what that means is that we have solutions for employers, for individuals, for families, for small businesses, really anyone who wants to take advantage of accessing direct primary care, but also emergency services. And you can't plan for that. You can't plan for having something happen to you in the middle of the night. You can plan for a surgery, but you can't plan for, a heart attack or something like that in the middle of the night. So, you've got your primary care side, right, that can really address, let's say 90% of your medical needs. But, what about that emergency side? It's a really nice partnership for DPCs. We do have an in-house DPC, but we also partner with just other DPCs in the area, because at the end of the day, we're just a community and we're all trying to be advocating for these patients. So we kind of fit nicely with them. So we're kind of the 6%. So we cover 96% of everybody's, really healthcare needs, with the exception of surgeries or something catastrophic, which that's why we obviously encourage you to have catastrophic coverage for those car accidents, right? Those situations you can't plan for. If that answers your question a little bit.
Yeah, yeah, absolutely. And it's always, what happens out of the primary care office that a lot of critics of the free market or the cash pay movement really point to. And to see a facility like yours occupying a vast majority of that, you mentioned that there are some limitations on services you can provide here. So I wanted to ask you, what type of trends are you seeing across the country in terms of emergent care? Are you seeing facilities like yours continue to grow and continue to pop up, or are you going to be more comprehensive, or are people looking at this and saying it's just not there yet? There's no way this kind of type of a center can work.
There's definitely not a lot of the independent freestanding ER that provides access to kind of that concierge treatment. So
Hmm.
the freestanding ERs are, yes, popping up everywhere, but you're still going to have the same issues that you have with going into a hospital ER. You're going to have waits. You have no idea what your bill is going to look like. So yes, those are still popping up, but the issue we're having and we're seeing is, part of my job, what I'm tasked with, is just educating, right, and getting the word out there that we are different, because there is a lot of steerage in our area, and
Hmm.
in Texas as a whole, but really with these companies I'm calling on and these insurance brokers I'm talking to, they're saying, hey, we don't want anybody. We tell them during open enrollment, don't go anywhere near freestanding ERs. They are the devil. So um,
Really?
we have to, yes, yeah. So we really have to try to explain to them why we're different. Look, we can help you control this crazy spend. I mean, there was a situation at a city in Texas, and there was $3 million in ER abuse that a city was faced with, and it was literally from, I think it was nine employees. They had hit their deductible, and they just started going to the emergency room and using it as their primary care, because they didn't have a primary care doctor. So they had already met their deductible, so they just kept going into the ER, and that was
Wow.
a huge issue, obviously, for that city to deal with. So that's my job, to go in and say, hey, let's get control of this. Your employees should be. We want them to be seeing a primary care doctor regularly, so they won't have to be going into the ER all the time. And then, we can look at some membership models, and you can pre-buy these emergency room visits for your employees. You can, pay for them up front, or you can pay at the end of the year, but it's kind of a flat fee, and you're not having to worry about, these crazy bills.
And I appreciate you going into kind of how the payment structure of the emergency center works there. But you said something, and that it kind of perked up my antennae here. The
Mhm.
concept that freestanding ERs are the devil. Can you explain a little bit more about what that means and why that exists, or why that
Yeah,
notion is prevalent?
yeah. It's because of the just the crazy unexpected um, bills that these employers are having to pay, and it's really unfortunate, but they're putting in places of what they're saying is that if and they've got employees that they feel like are quote unquote abusing ERs. They've been to the ER 3 times this year, and if it wasn't a true emergency, we're going to penalize you, which is terrible, because it shouldn't be the employee who's self-diagnosing what they have and trying to make that call on their own. So there is this steerage of, they're bad, do not go there. You go to you go to an urgent care, or you go to your doctor, but stay away from freestanding ERs altogether.
Okay. All right.
So
Yeah. So there
yeah,
people are so people within these plans, self-funded plans, for instance, are using ERs, and then, are they staying away from hospital owned ERs and just going to freestanding ones, or is this a
no,
problem for everybody?
I think it's just they're saying all ERs. They're just, the steerage is stay away from ERs, but especially stay away from freestanding ERs, because they feel like there's just it's it's not affiliated with a hospital. So
Mhm.
it's even more gray area. We have no idea what we're going to get charged. All of our charges there's no way for them to quantify that. So
Right. They're,
there's
it's all at a
definitely a lot of,
network or whatever that is, which is an interesting argument
yeah,
because they have no idea what that visit is going to cost them anyways to any type of a hospital ER. But I guess that's a different talking point to say the least here. So how do you get around that? How do you get around the fact that somebody's trying to vilify what you guys are doing and you're saying, no, we're the good guys. We're on your side. Look at here's our prices. We put them right on our website. You guys can figure everything out there.
yes, yeah, it's hard. And that's what I do all day long is meet with people and say, this is why we're different, because we can't market ourselves. We have to be very careful how we market ourselves to the public. So when you look at us, our facility says the emergency center. So it looks, and it's not attached to anything, right? It's a freestanding ER. So it's my job to have meetings and have these real discussions and say, hey, I know looks can be deceiving, but this is how we're different. And this is an introduction, and we want to partner with you. If it's a large broker firm, they have a lot of influence. We saw this yesterday. They have a lot of influence. So, it's my job to say, hey, look, this is how we're different. This is how we can actually help your employees save money by working with us, and how we are different.
Do you help those brokers and employers educate their employees?
Yes, yeah. It's I think education is, a big chunk of the change, right? It's just like you would have the DPC, if we're partnered with the DPC, going in and saying how important it is to have wellness checks and to have these events where they come out and meet with all of the employees and they do a physical. It's our job to go and educate during kind of that open enrollment period and make it fun and let them know who we are and this is how we're accessible. And when you come and see us, we have Spruce. We have the Spruce app where you can text us immediately, and you've got access when you leave our ER. You have access to a healthcare professional in the facility and a physician, and we're with you along the way after you leave. So education is huge. I'm glad you mentioned that.
Oh, absolutely. And we see that from a Freedom HealthWorks standpoint too, and educating not just patients or individuals, but educating physicians too. The fact that there are other options out there. You don't have to just push people down the same referral channels that don't work anyways. There are other options out there. So I totally agree with you that education is something that is so important to have and to just kind of revamp people's mindset and point of view. And that's something that is echoed on every single person that I've talked to in this industry and on this podcast. Everybody says the same thing. Education is where we can make the most impact from it. Peyton, I wanted to get your take again more on an industry level point of view here. I hear the word data being tossed around more and more within the direct care space. Some people use data as a way to say, look how awesome these doctors are doing. Data is our friend, data is our ally. It shows that this type of care model does work. I also hear from the other side saying that there's just not enough data out there to show that, words like quality. Where do you guys sit on the data argument, and how do you generate your own data, and what does that data show?
That is a loaded question, right? Like you said, there's a lot of there's a lot of noise out there as far as there's not enough data, there's plenty of data, or there's skewed data. So I feel like there is a lot of skewed data. It's hard to quantify, right? How many emergency room visits are level 1? How many are level 4? There's such a gray area because we believe a lot of things can be mislabeled. So the data is kind of a sticky question. So that's a hard one for me to answer. We are kind of conducting our own research and data, and the physicians that's why we're ever changing in this space, right? And just from conversations with, partnering with certain DPCs or talking to a broker, we're changing. We need to change our offerings. We need to do this more. And then, so that's kind of a work in progress, to be honest. The data
Sure.
conversation.
Sure. Yeah, not to be a trick question or anything like that, but it's always fascinating to see how these new innovative surgery center or emergency centers are using this. So let me ask it in a different way. What are you seeing most people use your ERs? What kind of services are they looking for?
When they're coming in off of the street, or if they are saying, hey, I'm interested in a membership.
Let's just talk walk-ins.
Okay. Well, I think it's probably similar to just anybody walking into any other freestanding ER, right? It could be or similar, I guess, to an urgent care. It could be I'm feeling sick, I have a sore throat, or I've just shot myself in the leg, which this has been in the last couple of weeks. We've had 2 gunshots, so and we can take care of those people.
Oh no! Yeah.
But it really ranges. I mean, from level 1 to level 5, we're seeing it all. So there's really not one or the over the other, if that makes sense.
Yeah, and you mentioned earlier that 96% of the people who come through, you're like, okay, all right, we can treat you. There's no wait. So looking at what you guys are doing and what you're able to accomplish down there, you have multiple sites set up throughout the state. Where's your growth coming from?
Yeah, we're still in the infancy stages as far as the offering memberships and through On Deck Health and partnering with brokers and employers and creating those connections, because it's a long kind of sales cycle, if you will, right? Because it's really new. It's new concept. You can sit down with an employer and say, hey, we can save you. And this isn't a conversation coming from me. This is just from some kind of forward-thinking progressive brokers, right? They'll sit down and say, hey, this is kind of your traditional model. This is what we've put together that's untraditional. And we can save you $500,000 a year, or even $250,000 a year. And they are so shocked and they don't believe it. It's too good to be true. And then
too good to be true. Yep.
Most of the time, they won't do it. They get scared. It's too new. They don't do it. Some people will go for it, right? Leap of faith. But 80% right now are not willing to jeopardize the company, right, and their reputation by taking that leap of faith. So really, where we're seeing this be very successful, and it's going to be a wave, right? And it's trickling and it's happening, but really with the smaller companies or even nonprofits that want to offer their employees something, and they can't afford healthcare. So these are nice offerings for them, because now that this is something that they feel is very kind of white glove concierge care, but it's not extremely expensive. It's very affordable.
Isn't that amazing that somebody can look at something and say, look, this is real. These are real numbers. These are real savings. Someone looks at that and says, no, thanks. I'm going to pass. I never understood that.
Yeah, it's interesting. It's interesting. And what I've been seeing is there are some more of these progressive brokers that will put together these plans, and they say, hey, look, I don't even make money until you save money. So the more money you save, that's how I pay my bills. So I am incentivized by saving you as much money as possible and providing you the best care for your company, and they still won't do it. So it's happening, but it's like you said, it's taking some time. Just education, right? It'd be so much easier if we could just have a PSA announcement and
get the shooting star, the more you know, right? Can we just bring those back?
Yeah. No, if we could have it, if we could have a PSA announcement. We've got TV ads, and if we could have the media talking about all of these forward thinking kind of the self-insurance world, but it's not that easy, right? This is very grassroots for everybody. So it's all about working together and just trying to change that thought process, right?
Indeed.
It's just,
Indeed. Well,
yep.
we talked about a lack of education out there in the market. We've talked about people's perceptions of or unwillingness to change, even for the better. What else limits, in your opinion, the growth of your ERs or other freestanding cash pay ERs in the U.S.? What else limits you?
That's a good question. I don't really feel like we have. Well, I mean, yes, there are limits, right? We have limits with insurance companies and working with them, and we don't want to rock the boat, if you will, right? So we want to stay in our lane. I guess our limits would be right now, because you and I have talked about this before, ambulance. the ambulance, we can only control what we can control, right? You can control the controllables. That is not one of them. So that's probably what we're limited with right now.
And just to give some color on what you mean there, if somebody is having chest pain and they dial 911, what happens in that process? Because I think that's a process that not many people are very aware of. Just walk us through what happens if I picked up the phone, dialed 911 and said, I'm having chest pains, I need to go somewhere.
Right. So that's a hard one to answer, because it depends, in Texas anyway, it depends on what city you're in. If you are in, the city where I live, if I call 911 and I get picked up by an ambulance and I say, I want you to take me to this freestanding ER versus that hospital, they'll do that. They should do that, because that's what the patient is requesting. There are some cities that have contracts with an ambulance fleet, and that ambulance fleet is contracted with the city, and the city says you only go to these hospitals, no freestanding ERs. So we don't, even if we have somebody who is a member of ours and they say, I want to go to the emergency center, they cannot take them there. And that's something that that's been a battle, but we haven't started that, because that's bigger than us right now. So we haven't started addressing that. We're really just trying to help as many people as we can, and that is a big fish to swallow right now. So we haven't started kind of chipping away at that. We're trying to, like I said, control what we can. So in those areas where the cities that don't have those contracts in place, we don't have that problem. Those people can say, I want to go to the emergency center, and they'll take them there. So that's great.
It's just something that I find absolutely fascinating, and something that I didn't know anything about. I figured it's kind of like when you walk into a room and turn on a light switch, the light just works. Most people are just like, oh, there's no problem here. I don't think about power coming from the plant all the way through the transmission lines, through transformers to my house. Same thing with picking up 911, which is a great service, in the US. But then what happens? How does the ambulance get dispatched? And then, if you are fortunate enough to be able to instruct the ambulance on where to go, and they're able to do that contractually, but it's fine. It's fascinating on the other end of it that some of these ambulances, these are my words, not yours, but some of these ambulance services have strict monopolies on coverage, on service area, and then they're able to cherry pick the best contracts to take them to the best hospitals. To me, something there just seems off. Not necessarily from a financial aspect, but what if these hospitals, what if these ERs that they're taking them to aren't really the best for whatever condition that you're being threatened with at that point in time? So there's a lot of questions that kind of pop up from this, and not gonna ask them here, but I'd encourage everybody out there to try to dig into this issue a little bit as far as ambulances. But so Peyton, we talked a little bit before. You said again that you're able to provide 96% of any services that someone can come through the door and need your help with. what is that other 4%? You mentioned surgeries. Is that the extent of it?
So, well, you have surgeries, you have a catastrophic event, you have a car accident that you can't plan for, right? So just the unknown. And that's why, having coverage, a catastrophic coverage plan is so important, because we can't plan for those and we can't always accommodate that. We can't accommodate if somebody needs a blood transfusion. We don't have that available to us. And that's when our facility there'd have to be a transfer. And, we arrange that. We have transport agreements and things of that nature, but we can't help those people, right? You just had an accident and you just removed half of your leg, was just cut off in an accident. We can't help you there, right? We have to send you out. But those are, thank goodness, rare events for a lot of people, but it's important to have that backup plan in place.
Yeah. Do you see people coming in and saying, "Hey, I need help this right now"? I mean, how do you handle something like that if that were to happen?
Yeah. We would immediately arrange to have them transported. We have had situations like that where they've, hey, this is bigger than us. You need a blood transfusion. We're gonna transport you, and then we transport them to the closest hospital. And then at that point, we don't have control over any quality, right, or any care. And this has happened. We've had one of our patients. It was having great care. She was treated, seen. She was put into a room. She was talking to a physician. She was given a warm blanket, and then she had to be transported because they couldn't help her. She needed a blood transfusion. So they transported her to the closest hospital, and she was waiting and waiting waiting. And she was just sitting and waiting. And it's just like, at that point, we can't control it. And that's what's hard for us, is we want, that's our owners created the emergency center because they are very passionate and ethical and care about their patients. And so when there are those times when they can't take care of them, that's challenging for us.
Oh, I bet you're able to comfort them at least, and then you got to send them off to a place where they have to take a number and get in line there. That's a sad story.
It doesn't happen often. Like I said, we have had gunshot, victims that have come in, and it's, thank goodness it's been, accidental and not life-threatening, but still, we were able to take care of them and treat them at the facility without transferring them out. And I'm just glad that they came to us instead of going into an emergency room. And I think that there are a lot of people, before I knew anything about this space or anything about the emergency center, hated going into an emergency room because I didn't like the care. I didn't feel like they cared about me. I didn't get any time with a physician. And if I did, I didn't feel like I was being treated with much respect. I waited forever. And so it's really, really special what the emergency room is doing, or the emergency center is doing, and to change kind of the face of that emergency room.
Do you get calls from anybody out there in different states for saying, how do I do this? How do I replicate what you guys are doing?
No, but we've had some discussions about, partnering with others to, and that's what the future looks like for us, whether it be kind of a micro, hospital, the emergency center, partnering with other groups is always on the horizon. Not something we're working on right now, but yes, that has come up in other states.
Yeah, and I'm looking at that and saying, how can we continue to spread this type of thinking? Whether you guys put emergency centers in all 50 states, all towns, big cities, everything, or there's other people out there who are interested in providing these type of services. So I think it's a benefit either way we slice it here. So Peyton, this is one of my favorite segments of Healthcare Americana here. So we call this the crystal ball segment. And it's where we ask you to gaze into your crystal ball and just kind of dream with us and tell us where you think your organization and the industry, where are we going from here?
Wow. Yeah, that's tough to see, right? I feel like it changes every week, right? Where we're going and what we want to do. But I think it's about educating people and, and trying to reach the masses one at a time. But, I see more and more DPCs popping up, and I think more and more people becoming these physicians, becoming independent and saying, you know what, we're losing this quality of care, and I got into this to take care of my patients, and I'm not doing that anymore, and I don't feel good about it, and I'm going to do this on my own. So we're seeing a lot of that. I do see more and more partnerships like this. You're starting to see these independent surgery centers that are contracting, and I think that this is just going to continue to evolve and to grow, and I'm super excited about it. And I'm so glad to be a part of this movement, and I think it's going to happen. I would like for it to happen sooner than later, but staying optimistic.
I like that a lot. I'm right there with you. Well, Peyton, thanks for taking the time to chat with us today. Wish you the best of luck and look forward to following all of your success.
Thank you so much. I was so glad to be a part of this.
Healthcare Americana is powered by Freedom HealthWorks, produced by Taylor Scott and iPodcast Pro. I'm Christopher Habig. Thanks for listening. Hi again, everyone. This is Chris. At Healthcare Americana, we're always on the lookout for great stories to tell in the healthcare industry. And we'd like to hear yours. Check out healthcareamericana.com and send us your ideas for episodes or if you'd like to be a guest. Thanks again for listening. Hope you enjoy it.